Hello? Can you guys hear me? Okay. So today we are going to discuss our remaining topics of red blood cell module. And believe me, they are going to be really interesting and like most high yield topics, I would say that USMLE loves to test. Okay, so let me just open my notes first. Okay. Can you guys just see my screen? Hello? No, sir. Okay, okay, just give me a second. Let me just fix my mic. Hello, can you guys hear me now? Hello? Hello? Hello?
Yes, we can hear you.
Okay, okay, perfect. So today we are going to discuss. Okay, let me just open my whiteboard. Okay, so today we are going to discuss some topics that is normocytic anemia, right? So in the last modules we discussed microcytic anemia, we discussed macrocytic anemia. Okay, so can anyone just give me a brief overview of macrocytic anemia? You guys have a lot of MCQs today, and I was just so happy you guys were just able to answer each and every MCQ. So can you just briefly give me an overview, Dr. Muskan, what we read yesterday?
Yes, doctor.
Yes,
So what
please.
is that about the macrocytic anemia? So
Okay.
for the macrocytic anemia, we know that MCV will be more than 100, okay?
Okay, so
But
we
for
discussed that MCV is going to be more than 100, and we discussed that basically the DNA helps in cellular division, right? Whatever
yes,
like causes disruption of your DNA is going to cause less cellular division, which is going to lead into macrocytosis or big cell, right? So we
yes,
discussed two of causes of that, folate, and you had an MCQ on folate and B12 deficiency as well. And Dr. Mahim told you that folate is going to be on the first, right? Most high yield, which you guys have to remember, folate and B12 deficiency. Okay, so it was
yes,
a brief overview of yesterday topics. So let's discuss normocytic anemia, right? So we discussed the classification of anemia based on mean corpuscular volume, right? So can you just tell me simply what's the normal range of ML? Yes, mean corpuscular volume,
it is 80 to 100.
MCV, normal MCV,
80 to 100 normal.
80. Okay, perfect. 100. We discussed whenever the MCV is less than 80, it's basically microcytic. Whenever it's more than like 100, it's going to be macrocytic. And whenever it's normal, that is normal size of your corpuscle or red blood cells, it's going to come into category of your normocytic anemia, right? So how can normocytic anemia occur? Right? The question arises that how can normocytic anemia occur? So it can occur in two ways. Like for example, if I have red blood cells, right? And they're normal in their size. Okay, let's suppose this is the normal size of red blood cells, right? So it can occur in two ways, right? Either you are having some destruction of your red blood cells, right? So it can just decrease the overall number of your red blood cells, leading to anemia. Am I right?
Yes, right.
Okay. On the other hand, if we have, okay, this was destruction, right? Destruction of red blood cell. On the other hand, we can also see anemia or normocytic anemia due to less ability of hematopoietic stem cell to produce your red blood cells. So there can be two causes of normocytic anemia. Normocytic anemia, normal mean corpuscular volume 80 to 100. What might be the causes of normocytic anemia? Anemia, decreased red blood cells. It can be due to destruction or due to underproduction, right? So, for example, if we have like anemia, so how to look whether it's due to peripheral destruction or it's due to less ability of hematopoietic stem cell to make RBC, right? So there should be some standard which we can follow in order to predict whether it's due to destruction, the anemia is going to be due to destruction, or it's due to less ability of hematopoietic stem cell to make RBC, right? So for that, basically, we refers to a term that is known as reticulocyte. So can you just tell me what is reticulocyte? Please raise your hand, reticulocytes. Those who want to answer. Okay, so Dr. Mariam, what do you think? What are reticulocytes?
Reticulocytes are the
Hello?
precursors. Yeah, these are the precursors
Okay, perfect.
of the RBCs, and
Can I
when
say that they are immature?
yes, immature
Can I
RBC.
say that they are immature red blood cells?
Sure,
Okay,
yes,
Yes.
we already discussed that RBC initially have nucleus, right? But once it's mature, the nucleus is going to be absent in RBC, right? So can I say that in reticulocyte, as it is immature, it will having nucleus, right? But with time, it's going to transition into mature state, that is anucleated red blood cell, right? So for example, okay, we were discussing how to predict or how to know whether the anemia is due to destruction or it's due to less red blood cells being produced by your bone marrow, right? So we refer to a term that is reticulocytes. Normally, for example, if we have, let's suppose I'm just, giving some random numbers. For example, if I have 100 of total red blood cells in my body, right? That's not true, but it's like I'm just giving you an example, right? An arbitrary number which I'm just assigning in order to make this concept like so clear, right? So for example, if you have 100 total number of red blood cells, remember, one or two among them are going to be your reticulocyte, right? So in these 100 total of 100 red blood cells, one or two cells are going to be your reticulocyte, or in other words, they are going to be your immature red blood cells having nucleus. Is that right? No?
Yes, right.
Yes.
Okay.
Doctor, it
So,
means that 2%?
sorry?
Is it mean 2%?
Okay, it's 1 to 2%,
Okay, thank you.
right? So can I say that normally I have 1% to 2% of reticulocyte? Can I say that? Okay.
Yes.
So, for
Yes.
example, if the reticulocyte count, let's suppose, decrease than this number, right? 1 to 2%. So, can I predict that somehow if I have less than one or two reticulocyte within these 100 reticulocyte, so it would just like somehow predict that yes, your bone marrow cannot make immature cell. Can I say that?
Yes.
Like it's
Yes.
going to be
Yes,
a
right.
simple concept, right? It's going to be a simple concept. Reticulocyte are made by your bone marrow, right? So if we have, okay, normally we have 1 to 2 reticulocytes per 100. For example, if I have an individual who is having like zero reticulocytes, so can I say that there might be some problems with his bone marrow which are unable to make red blood cell? Can I somehow say that?
Yes, sir.
Okay, perfect. But the problem with this statement, there is some problem with this statement. For example, if I have, let's suppose, normally we discuss we have 1 to 2 reticulocytes per 100 red blood cells. For example, if this 1 to 2 reticulocyte remain same, right? But the total of red blood cells are decreased. For example, if now I have 1 to 2 reticulocytes, but the total red blood cell, let's suppose due to some destruction, let's suppose like the total number come to 80. So now again, there is false elevation of your reticulocyte. Can you see that? Are you guys able to understand?
So
No,
can
can
you
you please?
Okay, no problem. Okay, we already know that whenever okay, for example, if we have an individual with anemia, so what his bone marrow are going to do, they are going to attempt in order to correct this anemia. And how are they going to do that? It would just start producing more reticulocyte. Can I say that?
Yes.
yes.
Hello?
Yes.
yes,
Yes.
Okay, anemia. So in case of anemia, if you have normal bone marrow or normal hematopoietic stem cell, so reticulocytes count should increase. Can I say that?
Yes.
Okay, so we were discussing that how to predict whether the anemia, the normocytic anemia, is due to destruction or if it's due to less production by bone marrow. That was the concept which we are now chasing, right? So for that, we discuss if you have anemia and if you have normal bone marrow, the reticulocyte count should increase because the bone marrow or the bones are going to, they're going to try their best in order to regain this anemia and make more red blood cell. But the immature form are going to be reticulocytes. They are the precursor, as doctor told us, which are going to in future get mature into red blood cells. Is that right?
Yes.
So till now, we just made two statements. If we have an individual who is having anemia, and if he have normal bone marrow, so reticulocyte count should be increased. But if the anemia is due to less production, the reticulocyte count would be decreased. Is that clear?
Yes.
Okay. But we have a problem with this statement. How? We can have false elevation of reticulocyte. How? For example, if we have destruction, normally we discuss, okay, we just took an arbitrary number that is 100, right? And normally we discuss we have 1 to 2 reticulocytes. Is that clear? For example, if what happened that now the total number of red blood cells are less, right? Here you can just calculate the percentage. What's the percentage going to be here? 1% to 2%, right? But in this case, for example, if the total number of red blood cell decreases, so now how to just find out the percentage here? How do we find percentage? You guys know 1 divided by 100 multiplied by 100. So it's going to be 1%, right? Or for the 2 divided by the total number of RBC, 100 multiplied by 100. In order to, it's some mathematics you guys should know. This is how we just find the percentage. Is that clear?
Yes.
Yes.
Here, let me just find the percentage. We know the mathematical equation. So 1 divided by 80 multiplied by 100. Now you can see this cancel out the 0, 2, 5, 4, 4 into like 1 and 1 point, like something, right? So if it's decreasing more, right? Let's suppose if it comes to 60, then let's find the percentage. 1 divided by 60 multiplied by 100, right? So like you guys can see as the total number of red blood cells are decreasing, the percentage is increasing. Here you guys can see when the total red blood cells come to 80, it increased by 0.5%. When it comes to 60, it increased by like 1 point and some more, right? For example, if it comes to 50, so 1 divided by 50 multiplied by 100, you guys can see it's subsequently increasing, right? The reticulocyte count. Although we have normal number of reticulocytes, but as the total number are decreasing, the percentage is falsely elevating. Can you guys see that?
Yes, I
Yes.
got it. Yes,
Yes.
Did you guys get the concept?
yes, thank you.
Like come down. Okay, let's decrease it some more, right? For example, if it's, let's suppose 20 now. So 1 divided by 20 multiplied by 100. Again, it's like decreasing, right? So what happens that if the total number of reticulocyte are decreasing, it can just falsely elevate the reticulocyte count, right? So for that, we are going to use a term that is known as corrected reticulocyte count. Is that clear?
Mm-hmm.
So I've got a question.
Yes, please.
So the increase in the reticulocyte count when there's a decrease in the RBC is gonna be because of the bone marrow that's trying to compensate, right?
Yes.
So it's like it's not gonna be a false increase, but then it's the bone marrow that's increasing the reticulocyte count.
Okay. So, okay, let me just clear out that doubt, right? Okay, so we discussed that, for example, we can have anemia, right? Normocytic anemia. Let me just come from really start, okay, and try to make this concept a little bit more easier, right? So we discussed it can be due to peripheral destruction, or it can be due to underproduction, right? Is that clear?
Yes, sir.
Okay. How do we have underproduction? If you have problems with your bone marrow, right?
Yes.
Right. But if you have problems with the bone marrow, it means that if you have less production, it means the reticulocyte count. What would happen to reticulocyte count?
Decrease.
Decrease, because bone marrow isn't able to make, right, some reticulocyte. But if we have peripheral destruction, it means that your bone marrow is fine, right?
Yes.
Okay, so it means reticulocyte count is going to be more. That is like more than 3%, right? In this case. Is that clear?
Yes.
But
Yes.
sometimes what happens that we know that we have 1 to 2% of reticulocytes. Like for example, 1 to 2% basically means that in every 100 red blood cells, we are going to have 1 to 2 reticulocytes, right?
Yes.
But for example, if you have same number of reticulocytes, but you are like decreasing the overall, so what happens that the proportion or the ratio or concentration of these reticulocytes as compared to like now 80 or 60 or like 20, it's going to like somehow be falsely elevated, right? The percentage is going to be shifting and you are going to see more percentage, but that could not tell you that we have. Are you just getting me?
Okay, so in
Hello?
this case, the bone marrow is not gonna give the reticulocytes, but then the RBC is gonna keep decreasing.
Okay. Actually, the point here which I want to mention is that you have, okay, let me just tell you, right? So the reticulocyte count basically is like, we are going to use a term. Okay, let me just tell you the equation, then everything is going to be clear, right? So we have a term which is known as corrected reticulocyte count. What do we mean by corrected reticulocyte count? In the U world, you are going to, like, they are going to give you reticulocyte count, first of all, right? But you don't have to look to reticulocyte count because it can be falsely elevated. That is the concept. So you have, first of all, you have to use a formula for that. The formula is corrected reticulocyte count. So you are going to take the reticulocyte count, which the U world or the question mentioned. You are going to multiply it with the hematocrit and divide by 45. The hematocrit given there in your question stem. Is that right? In order to avoid false elevation or false reduction of your reticulocytes. Is that clear?
Yes.
Again, is this concept, please?
Hello?
Can you repeat this concept?
Yes. Okay, no problem. Okay, just give me a second. For example, like let's suppose we have, okay, we have 4 numbers, right? Is that clear? Hello?
Yes.
And for example, let's suppose okay, let me just give you an example. If we have like a community having or a group having 4 people, right? And one among them is like let's suppose he's like all of them are, let's suppose, American, and we have one, let's suppose, a Canadian individual, right? Simple. For example, if I want to calculate the percentage of Canadian individual in this community, so what would be that?
1/4 into 100.
Okay, 1/4, right?
Yes.
For example, if I'm just removing out one, one individual, and I'm then, okay. So for example, if I'm just removing out, so again, it's going to become 1/3, right?
Yes.
Okay, if I'm just removing it, so it
One
becomes
by
1/1.
1/2.
So what do you think?
Oh, yeah, 1/2.
Okay, okay,
1/2.
okay, 1/2, by the way. Okay. So can you just see that we still have a single individual, right?
Yes.
But his percentage among the community is dependent on the total number of the people in the community. Is that right?
Yes, right.
Is that clear?
Mm-hmm.
Okay. So this concept can be applied to this as well. Like for example, if I have 1 to 2 reticulocytes per 100, right? Although we have still single Canadian, right, among these American people. Are you
Mm-hmm.
guys able to understand? Hello?
Yes.
But it depends on the number of people in the community as well. So it's like falsely elevating, right? Now, like, the constant, if you are just finding the percentage, so you are going to get like the percentage is going to, like, the percentage is changing. Is that clear? Still, you
Yes.
have a single Canadian, but the percentage is changing. So this concept can be applied here as well. Sometimes you can have like constant number of reticulocytes, but based on the overall number of the red blood cell, it can be changed, right? The
Yes.
reticulocyte count can be changed. Is that clear now?
Yes.
Hello, are you guys able to understand? Those who just asked the question?
Yes.
Yes, sir. Thank you.
Okay, Dr. Tarun. So, can I say that now I should not always believe on reticulocyte count because I have problem? What's the problem? It also depends on the number of people in the your community. So it means I have to use the term corrected reticulocyte count. Is it clear? And these are the distractors which basically you are going to see on your MCQ. You should not directly go and see the reticulocyte count. First of all, you have to correct it. Is that clear, Dr. Tarun?
Yes, sir.
That was the concept,
Okay, so the
right?
corrected count is the normal value
You are going to
multiplied
okay.
by.
Okay, you are going to put down the given value in the question in this formula. Take the reticulocyte count given in your question. You have a UL MCQ, and I believe that if you did not correct the reticulocyte count, you are going to do that wrong, right? So you are going to put here the given reticulocyte numbers and just multiply it with the given hematocrit. It will also be given in your question stem divided by 45. Simple is that. Then look into corrected reticulocyte count. If it is more than 3%, it just indicates that it's anemia due to destruction. Is that clear?
Yes, sir.
And if it's less than 3%, it means it's anemia due to underproduction. That's all. Is that clear?
Yes.
I think it was a little bit, a concept which involves like a little bit of maths. So I want someone to, do a little bit discussion. So Dr. Gyanshi, okay. Dr. Gyanshi, can you please turn on your mic? Okay, Dr.
I
Ramesh?
can I can do it.
Yes,
Okay.
okay, Dr. Tarun. Okay, so half for Dr. Tarun, half for Dr. Ramesh. So Dr. Tarun, I want to ask you a question that we can have two types of normocytic anemia, right? So
Yes.
how can we get, like, by the way, normocytic anemia?
So normocytic anemia is either there's gonna be decrease in the RBC that's been present due to peripheral destruction, or there's gonna be reduced production.
Okay, so okay, let me just there is a okay. Okay, so let me just spend some more time on this concept because I think sorry I'm not much confident about this yet. Okay, okay. So Dr. Tarun, can you just please tell us
Yes.
the two variants due to which we can have anemia? One is due to destruction, another is due to underproduction, right?
Yes.
Can you just tell us what are reticulocytes?
So reticulocytes are basically immature red blood cells that are being released from the bone marrow,
Okay, okay.
and
So
the normal value is 1 to 2%.
okay, the normal value is 1 to 2%, right? So
Yes.
we discussed here that okay, we discussed whenever we have anemia due to destruction. We discussed if we have anemia due to destruction or peripheral destruction of red blood cells. What happens? The if you have normal functioning bone marrow or bone, what happens? The reticulocyte count is going to be increased. Is that clear?
Yes.
But if we have anemia due to underproduction of your red blood cells, so what happens now? The reticulocyte count should be decreased because the bone is or the bone marrow is unable to make immature reticulocytes, and then in turn they would be just get mature into red blood cells. Is that clear?
Yes, sir.
But you cannot always trust the reticulocyte count because sometimes we can have false elevation, right? And the concept for that is that okay, let me just like uh, give you the same example again, right? So Dr. Tarun, can you just please explain? I'm just thinking that what's the point, okay, okay, what's your questions? Can you just ask me questions? What's your doubt about the topic? What's unclear? Yes, Dr. Muskan, what do you think? What like
Doctor, I want to ask you that are you trying to say like whenever there will be destruction of RBC, so reticulocytes must increase. Yes.
Yes, it must increase. Like how
Yes.
do it increase? How do if you have normal bone, if you are normal bone, how do it increase? Normal bone would just make more, right?
Yes. Yes.
Normal
Right.
bone is going to make more, but sometimes with anemia you can have false elevation. Like for example, if you have anemia, let's suppose if you have anemia due to destruction. Okay, so we have three cases, right? Three cases. Let me discuss three cases all in detail, right? The first case, what happens? You have peripheral destruction. It means you are going to have anemia. But
Yes.
in attempt to that, if you have normal bone marrow function, what your bone marrow is going to do? It's going to produce more
Reticulocyte.
reticulocyte, right? So the reticulocyte count is going to be more.
Yes.
Okay, let me just draw down the second case. For example, if you have peripheral destruction of red blood cells, but you have defected bone marrow,
Bone. So
right?
low
Still, what happens
reticulocyte.
to the reticulocyte count?
Decrease.
Listen, it can be falsely elevated.
Okay.
Ah,
Yes,
I
defected
got.
bone, right? Still, you have
Hmm.
1 to 2%, like a small number, but you are decreasing the total, so it's give you false elevated percentage. So you cannot always trust this statement, right?
Yes, like it is
Yes, sir.
supposed to be. It is supposed to be decrease, but it is not decreasing. Yes.
Yes, in turn it is increasing. Why? Because you have like
For
one reticulocyte. Okay, you have four people, one Canadian, right? One Canadian, and and the other three are American, right? So in this case, like still you have one Canadian person because the bone is defected. Still you have that same reticulocyte, but you are decreasing the peripheral or the overall number of red blood cells. Is that clear now?
yes, of
So you
course. Now
cannot trust reticulocyte count. You will always trust corrected reticulocyte count because you are going to look for the concentration within the hematocrit.
now it's clear. I think it's clear for everyone.
Yes, anyone else? It's okay. We can just spend a lot of time on that because like it's something which, deals with the mathematics and things. And, I think it should be cleared now.
Yes. It's
Yes.
Dr.
clear.
Amit, what do you say?
Yeah, doctor, it's kind of like clear.
Okay.
So
Let's
like so you can always like keep an eye on the hematocrit.
correct it.
If it is like close to 45, then we can simply go by the number that is the reti count that is given. But if we
Yeah.
like think that the hematocrit is kind of deviated from 45, then we have to like correct the corrected reticulocyte count. Or if we can like believe that there are reasons that hematocrit can deviate, even it is not given, but hematocrit can deviate from 45, then we have also always like trust the corrected reticulocyte count.
Okay. Just whenever you see reticulocyte count, don't trust that. Simply, just
Yeah.
put it in the formula first. Simple is that,
Mm.
right?
Yeah. But
Okay. Okay. So let's we just spend a lot of time, but I think like that was the first one I would say of this topic. So the other things are going to be so simple. So let's discuss our next topic that is going to be peripheral destruction, right? So peripheral destruction of red blood cell. What do we mean by that? That red blood cells are destroying peripherally, right? Not centrally, not in the bone marrow. But now we can have two situations. Either the red blood cells can destroy within your within your blood
Vessels.
vessel. We discussed that Maha. Remember, within the blood vessels, we are just seeing destruction, cystocyte, helmet cells. Remember,
Yes.
but red blood cell can also be destroyed where outside of your blood vessels, outside of your blood vessels. That is in the spleen, right? So it's basically divided into two variants. That is intravascular hemolysis or extravascular hemolysis. That's so simple, right?
Mm-hmm.
Okay, so let's discuss some of the extravascular hemolysis, right? Okay, so what do you think? How can we have extravascular hemolysis? Does anyone know about that? Where do we have extravascular hemolysis, by the way?
Yes,
We
extravascular.
discussed what.
Yeah, how will we
What
get to the
Okay.
how to fix all problem?
Okay, we can't hear you. Can you just please fix your mic and tell us?
Doctor, extravascular hemolysis, I think it's gonna occur in spleen, liver. Yes.
Perfect. So we can see it in spleen, liver, and lymph nodes, right? Okay. So what happens after extravascular hemolysis? The idea is going to be really clear now. What happens if the red blood cells if you're destroying the red blood cells, it means you're destroying the hemoglobin as well, right?
Yes, right.
Hemoglobin is going to be broken down into heme plus, globin,
Glo-
right? Further, you can just break it down into iron plus protoporphyrin, right?
Yes.
And you can just break down the globin chains, and they're basically amino acids, so you can just use it, right? You can just reabsorb the iron for further production of red blood cells. What about protoporphyrin? It's going to be like passing into certain intermediate steps, and ultimately it's going to be converted into bilirubin, right? Is that clear?
Yes.
Okay, and this bilirubin is going to be, okay, it's a direct bilirubin or indirect?
Indirect.
Okay,
Indirect.
indirect. So
Right.
what your albumin is going to do, albumin is going to be attached to this bilirubin. It's going to take it into the liver, and liver is going to be conjugated. And once it's conjugated, it have the ability to either be, excreted in your urine or your stools, right?
Yes.
Giving the color of it. So that's a simple pathway, right? So if we have extravascular hemolysis, so this is going to happen. Okay, besides that, the hemoglobin, whenever present in the blood, is like not too good. Remember that, right? So for example, if we have like red blood cell and you have like hemolysis, it's destroying it, jumping off its hemoglobin. So hemoglobin itself can cause a lot of problem. Remember that. One of the problem we discussed, acute tubular necrosis. Do you guys remember that? The crush
Yes.
injury, myoglobin, causing acute tubular necrosis. How can you forget that?
Yes, sir.
Yes, and if we have acute tubular necrosis, can I say that it would just lead to ischemia of your kidney? Can I say that?
Yes,
Can I say that you can have like a flank pain?
yes.
So can I say that
Dull aching.
hemoglobin?
Yes,
Yes, can I say that hemoglobin can cause back pains?
Yes.
yes,
Hemoglobin itself can also activate your coagulation cascade. It can cause, yes, thrombosis, right? Hello?
yes,
Okay, so these are the things which you guys should just keep in mind. But remember, whenever you have free hemoglobin, okay, this was all of the discussion of free hemoglobin, right? Free hemoglobin. So whenever this hemoglobin came out, as we discussed, that it's like quite fatal for our body. It can just cause destruction of your kidney. It can cause problem like, for example, thrombosis. It can cause thrombosis, like it can cause everywhere, right? But for that, nature have given us a mechanism in order to avoid these outcomes of your hemoglobin. What's that? Haptoglobin,
haptoglobin.
right? Perfect. Haptoglobin. So haptoglobin from your liver is going to be released normally. And if haptoglobin finds some free hemoglobin, it's going to catch them, right? In order to
Yes,
avoid causing problems, right? So you're going to have a lot of MCQs, a lot of lab values. If the haptoglobin is less, it suggests, can I say that whenever the haptoglobin is less, it suggests hemolysis?
yes.
Yes.
Intravascular hemolysis.
Yes, and why? Because haptoglobin catches free hemoglobin, and free hemoglobin comes from hemolysis. Is that clear?
Yes,
Okay, that's perfect. So let's have a small revision of whatever we discussed. These are going to be like, I would say, highest shield topics. So that's why we are just going to spend some time today, right? So just be here and just don't worry, right? So let's discuss from the beginning. We discussed that we were discussing normocytic anemia. So normocytic anemia can be due to two causes. Either it can be due to destruction or underproduction of red blood cells, right? Okay. So we discussed whenever we have destruction, so your bone marrow is going to attempt, and like it's going to give an attempt in order to like make everything things normal, right? So what would it do? It would just make reticulocytes, which we discuss are immature red blood cells, which in future are going to be converted into mature red blood cells. Is that clear?
Yes,
Yes.
clear.
So if the bone marrow functioning is like fine, right? But sometimes it can be due to underproduction. For example, if you do not have functioning bone marrow hematopoietic stem cells, so it can also lead to anemia, because if you do not have the myeloid lineage, you won't be having any erythrocytes, nor erythrocyte, nor red blood cell. Again, anemia. Can I say that?
Yes.
But you cannot directly like you look towards reticulocyte, because we can have false elevation of reticulocyte if you have like a peripheral destruction, as we see in this case. Although we have peripheral destruction with defective bone or defected hematopoietic stem cells, still it was leading to increased reticulocyte count. It was just a distractor, right? So what we are going to do for that, we are going to use this formula. Is that clear? Okay, let me just open the chat. Okay. Just give me a second. One of the student was okay. Dr. Divanshi, is it clear now? Hello.
Yes, it's
Dr.
clear. Thank you so much, everyone. Thank you,
Okay.
Dr. Ahmad.
Okay. Okay. So then we were discussing different types of hemolysis. It can be intravascular within the blood vessels. It can be extravascular outside, spleen, liver, right? We discussed the concept of like the hemoglobin being converted to hemoglobin, globin into amino acids, heme into iron being reabsorbed, protoporphyrin into indirect bilirubin. It get into the liver, conjugated. You can just excrete it out in your urine or stools, right? Simple. Whenever we have free hemoglobin, we discuss, it can cause problems. It can cause acute tubular necrosis. It can give you back pain, flank pain. It can also cause thrombosis. So we do not, want free hemoglobin to be accumulated inside our blood. So for that, nature has given us a mechanism, haptoglobin. It would just come, it would just attach with free hemoglobin, and that way it will just avoid the outcomes of free hemoglobin. Is it clear now? I think things are so simple.
Yes.
Okay, perfect. So let's move to our next topic, a really high yield one, that is hereditary spherocytosis. So it's so like I would say the highest yield one, and I would say at the same time the simplest of all, right? Hereditary sphero, and I'm going to mention some of the UWorld MCQ. So tomorrow you guys are going to be like alert while solving the MCQ. Spherocytosis. What happens in hereditary spherocytosis, as the name indicates, spherocyte. What is sphere? Sphere is a round ball, right?
Yes.
Normally, the red blood cells aren't supposed to be a round ball. Normally, they are going to be like, biconcave, right?
Yes.
Yes.
But if it's sphere, okay, how do we have biconcave? So can I say that inside I must have some ropes, right? Ropes or some threads,
And
holding this structure.
drinks.
Yes, holding this structure in its appropriate location in order to give me this complete and this structure like biconcave. And it's so important because if it have this biconcave structure, it will be quite flexible, right? It's flexible.
Yes.
It can pass into
Yes.
small doors, right? Like in the liver sinusoid, we have like a small doors. So what happens if you have normal structured red blood cells or normal functioning red blood cell? So what happens in the spleen sinusoid, in the red pulp, it can easily squeeze there and it can just move out, right? So it won't be killed there,
Yes.
right? But if it's old, and if it's weak, the spleen is going to kill it. Why? Because spleen is, we discussed, it's graveyard of red blood cells. Is that clear?
Yes.
Okay. So can I say that this ball form of, this spherocytosis or this sphere shape or ball shape, can I say that you do not have, like a good amount of supporting pillars or supporting threads or that ropes, which are able to hold it into place and giving it a beautiful structure biconcave. Can I say that it might be due to, yes. So they are basically, can I say that these are the cytoskeleton? These are the skeleton of your, red blood cell, cyto for cell skeleton, right? So can I say that
Yes.
this hereditary spherocytosis must be, arising due to problems within this cytoskeleton, right?
Yes.
Okay, and what cytoskeleton, or let me just name these cytoskeleton or ropes as well: spectrin, ankyrin, and bentry, right? Spectrin,
Yes.
ankyrin, and band 3. Tomorrow you are going to see this UWorld MCQ. If you didn't see, so then tell me that Dr. Ahmad, you were just you were just lying, right? So they are going to give you an MCQ. They are going to give you a picture. In the picture, they are going to clearly give you balls of red blood cells, appearing in the form of balls. They are going to tell you what's the problem going on. So you already know. Is that clear?
Yes.
Yes,
Okay.
clear.
Okay. Okay. Now we have ball-shaped red blood cells. What's the problem? What's the problem with that? The problem with that is that now it cannot pass through that spleen sinusoid. Once if it's passing through the spleen sinusoid, it would be killed. So can I say that its life becomes shorter? Can I say that?
Yes.
Okay. Although it have proper hemoglobin, and although it can if it have proper amount of hemoglobin, so the oxygen carrying ability of this ball in this case is still fine. So O2 carrying capability is still fine. Can I say that?
Yes.
But the problem is that now they have less lifetime. Why? Because they cannot survive through that small slit or small sinusoids within your
In the
spleen,
spleen.
right?
Yes.
So what should I do for that? What I can do is just remove the spleen. Remove the spleen. Can I do that?
Yes.
What else we discussed? I guess something about. Yes. What else we can do? Hello?
Uh,
We can do
hydroxy.
bone marrow.
To
Bone marrow.
divert macrophages by giving immunoglobulin?
Okay. Was that for hereditary spherocytosis or something else?
No, it was not for this. It was
Okay,
for
so we will just do splenectomy, right? So that's going to be the treatment option, right? But what are the problems which are going to arise due to splenectomy? We discussed thousands of times, right? Invasion by which bacteria?
Encapsulated bacteria.
Encapsulated. Why and why is that so? Just remember your immunology module.
Yes.
Yes. Why do we
Because
have?
Because we
Yes.
have B zone there in
because
the white bulb. B cells were there. Yes.
We
They
discussed that spleen is a big reservoir for your antibodies, and in order to kill encapsulated bacteria you need these bacteria to be tagged with antibodies and the complement system in order to destroy that. If you do not, if you just loses the big reservoir of your antibodies, so can I say that now I'll be having more chances of encapsulated bacterial infections? Can I say that?
yes. Yes.
Okay. Okay, so as we discussed that now we are having sphere shape or red blood cells, so they are going to be weak. We discussed that. So there is basically a test which is known as that is basically a test of diagnostics as well. That is osmotic fragility test. So what do we mean by osmotic fragility test? Yes.
We will increase the osmolarity in the medium around the red blood cells, and if they are in sphero shape, they will hemolyzed.
Okay,
Yeah.
we'll increase the osmolarity
If
or decrease the osmolarity.
if we
Decrease.
place
Hypotonic solution.
decrease.
yes, if
Okay,
we
we
place
will decrease. We will just put it into a hypotonic solution. What do we mean by hypotonic? That the osmolarity there is going to be low. So what happens? All of the water is going to be moved into the cell. If it's weak, the cell is going to burst. Again, you have a UWorld MCQ.
Okay.
Test for diagnosis. Is that clear?
yes.
When the water will go at the RBC, it's gonna burst. So what?
Yes, it's going to
Then-
burst. Why? Because we do not have that ropes, that strength, right? So it's going to burst. It's going to be really fragile. Is that clear?
Yes.
Okay. So let's discuss our next topic. Dr. Maheen had a great discussion on that, sickle cell anemia, right? So this is going to be our next topic, the sickle cell anemia, and it's going to be, believe me, like a really high yield one, right? So Let's discuss our next topic, that is sickle cell.
Excuse me, Dr. Ahmed, I have a question, please.
Yes,
Uh,
please.
Actually, the splenectomy is the treatment for the hereditary spherocytosis,
Yes.
and the splenomegaly is going on if the patient having the hereditary spherocytosis. So,
Yes.
the encapsulated bacterial infections we develop after the treatment,
After
or
the treatment. After the
yeah,
treatment.
yes,
Okay,
it's
we are
clear.
also going to see some other bodies, Howell Jolly bodies. How can we forget that? What are Howell Jolly bodies if we remove your spleen?
Mm.
Yes.
Yeah, uh, sorry, what are you asking?
Okay, if we just remove the spleen, we can have
Mhm,
two things, right? As a
mhm,
complication. First of all, we can have invasion of encapsulated bacteria, invasion with encapsulated bacteria. And
mhm.
secondly, we on the peripheral or the blood smear, we are going to see Howell Jolly bodies. So what are
Yes,
Howell Jolly bodies?
these are the nuclear remnants which can be cleared by the spleen. So we can assess if there are
Oh,
Howell joint bodies in the peripheral smear. So it must be the splenectomy there, or the treatment is there.
okay,
Yes.
perfect. So we discussed that the normal or the mature red blood cell do not have any nuclear remnants there, right? So it's a job of your spleen to remove the nuclear remnant. If you do not have spleen, now the nuclear remnants are going to be seen within your red blood cells, which are basically termed as Howell-Jolly bodies. Is that clear? Hello?
Ye-
Yes.
Yes.
Okay. So let's just
Yes,
take
sir.
our discussion. Okay, why the participants are leaving? What happened? If you guys are just bored, we can just continue tomorrow. No problem. Hello?
No, no.
No,
We can.
let's
No,
let's
we're okay.
No, sir.
No,
No,
maybe sir, it
we
would be
can
late
continue
in
today.
their timeline,
Okay,
like
okay, no
time
issue.
zone.
They can just look for the recordings. But believe me, like the hematology section, I would say that it's like the most interesting and at the same time most difficult one for the students as well. So that's why we are just taking some time on that, like doing a lot of discussions. Okay, so let's discuss sickle cell anemia or sickle cell disease, sickle cell trait. So can you guys just tell me what's the main theme of sickle cell anemia, right? Before going into what's the problem, so what's the main theme? As we are just doing pathology, so we must know the theme. What's the theme of this pathology?
Doctor, it is a
Sickle.
hereditary condition, okay, in which what happens, there is a replacement like of amino acids, that is the glutamic gonna replace by the valine.
Okay. So okay, just let's look for a bigger picture, right? Sickle cell, right? So sickle, it's going to be in a form of sickle, right? What's
Yes.
going to be in a form of sickles? Red blood cells, right?
RBC.
Okay. Normally, we discuss that red blood cells are like going to be are supposed to
Biconcave.
be biconcave, right? But if it's sickle, so can I say that now it cannot undergo its normal function? And what's the normal function? Oxygen, carrying oxygen to different tissues, right? So can I say that now the oxygen carrying capacity in this pathology, as the name indicates, is going to be disrupted, right? The oxygen carrying capacity is disrupted, right?
Yes.
Yes.
But how can we have this sickling? Remember, normally in this disease, we won't be seeing like direct sickling. Whenever we have stress, like whenever stress come on red blood cell, they'll be just shrink and they'll be just converted into sickle shape, right? And once it's converted into sickle shape, what's the problem? The problem is oxygen carrying capacity is compromised, oxygen carrying ability of your red blood cells is compromised. Can I say that?
Yes.
Okay, so for example, okay, one of the stress can be hypoxia. Hypoxia is a stressful situation, right?
Yes.
So can I say that whenever the oxygen carrying capacity is disrupted, it can lead to infarction if it's severe? Can I say that?
Yes.
Yes,
Mhm.
sir.
Are you guys able to understand? Like it's some simple discussion, right? I would say like a common sense. Are you guys able to understand? Hello?
Yes.
Yes, sir.
Yes,
Okay, so we
we
can have
can.
infarction. Okay, infarction where? In the small blood vessels. Why? Because if we have like a small blood vessel, these sickles cell, although they have less oxygen carrying capacity, and in the small blood vessel, they cannot even pass further, right? So they cannot, if even if though they have less amount or little amount of oxygen. So the other problem is that in the small blood vessel, they cannot move through that, right? So the organ which these small blood vessels are supplying, or the tissue which they are supplying, are going to become infarcted. Can I say that?
Yes.
Okay. So whenever we have infarction, whenever we have ischemia, it's accompanied by ischemic pain. Can I say that?
Yes.
Right. So for example, if the same process happens in your, let's suppose, small vessels of your fingers, right? So can I say that it can lead to like ischemic pain?
Yes.
And what's what's this condition called? What's the name used for
Reynolds
that?
phenomenon.
Vaso-occlusive crisis.
Okay, vaso-occlusive crisis, dactylitis, right?
Yes, sir.
Okay. So you have a UWorld MCQ in which a child is going to appear and like they are going to give you some of the clues that his father had like the same condition or thing with like painful, fingers, right? Extreme painful fingers. So you guys should know that on your differentials, the sickle cell disease should also be present there, right? So you have a UWorld MCQ on that. Is that clear? Okay, the same thing can happen to your, the small blood vessels which are supplying your spleen, right? So as we know that this sickle cell disease, it's a chronic condition, right? Once you have like sickle cells, you're going to have that throughout your life, right? So throughout your life, there are more chances of getting, stress or hypoxia, right? So can I say that if we have like recurrent hypoxic, event in the spleen, so ultimately in its chronic phases, the spleen can die. Can I say that?
Yes.
Yes, sir.
So the death of spleen, it's basically due to sickle cells. Sickle cells are not able to, provide with the oxygen to your spleen, so it can undergo death or autosplenectomy. Can I say that?
Mm-hmm.
This
Yes, sir.
again is going to be your UWorld MCQ, right? So you're going to have autosplenectomy. And whenever we have autosplenectomy, two things should directly hit your brain. Encapsulated bacteria. And what about Howell Jolly bodies? Is that clear?
Yes.
So
Yes.
I think now you guys should be pro in the USMLE topics, that how to associate things. Is that clear? So this was
Yes.
like a general overview. Now let's come to the genetics. How do we get this condition? How do we get this condition? We discussed that we have alpha and beta chain, right? So as Dr. Muskan told us, what happens, the glutamic acid is replaced by valine. You can just simply memorize it. And once it's replaced, then we are going to have this condition. You know the condition, what we are going to see. Once we have like uh, stressful situation, once we have like hypoxia, your red blood cells are going to be converted into small sickle shape, and it's going to cause problems. Is that clear?
Yes.
Yes, sir.
Okay. So as these sickle cell cannot, like their lifespan is also going to be much less, right? So they can be destroyed in the reticuloendothelial system, right? So it can also lead to hemolysis. Is that clear? Because the shape is disrupted, so there are like more chances to have, death of these sickle cells. Can I say that?
Yes.
So can I say if you have death of red blood cells, these sickle cells, so it can lead to anemia.
Yes.
You can have severe anemia, right?
Yes.
Right? If we have severe anemia, we discussed today in the MCQs as well, extramedullary hematopoiesis. Did you guys remember? Yesterday we did extramedullary hematopoiesis. And what happened? Your body is going to tell even the primitive structures, your spleen, your liver, to please just make some more red blood cells for me, even to your skull, even to your faces, which would appear in the form of crew cut appearance, chipmunk faces. Is it clear? Extramedullary hematopoiesis. Hello?
Yes.
Yes,
Yes.
sir.
Please.
Here.
Okay, perfect. And we discussed like dactylitis and autosplenectomy, Howell Jolly bodies. You can also have vaso-occlusive events in pulmonary circulation as well, right? So three things we discussed in the fingers, in the spleen, and in your pulmonary circulation, right? And in the pulmonary circulation, you can have like shortness of breath, chest pain, periodic pain, and pain crisis. If you guys remember, like we discussed in the renal section, remember? We discussed that we have our cortex and our medulla, right? Do you guys remember the cortex and the medulla. We discussed that, right?
Yes, sir.
And we discussed that at even in the normal states of your kidney, right? Whenever you have normal blood supply to the kidney, so the medulla get very little blood supply, even at normal, normal perfusion. Are you clear? Hello?
Yes.
Yes.
Yes, sir.
Right? So
Yes, sir.
can I say that although even if you have normal perfusion to your kidney, still the medullary portion of your kidney is like normally getting like least blood. But if upon that, if the same person or if this normal person develops sickle cell disease, so can I say that this area is going to be more prone toward ischemia? Because although normally it's getting so less blood supply, and if now you are just, integrating this disease as well, just getting sickle, so what happens to this small microvasculature? This area is going to be prone to death, to ischemia. Is that clear?
Yes, sir.
Okay.
That's why they are prone to having papillary.
Yes, that's why we are going to have renal papillary necrosis, which you guys missed today when Dr. Mahin was asking. Right? So this is going to be the reason, this is going to be a process. Okay. So we can have two variants. Either we can have sickle cell disease or sickle cell trait. So I'll be just leaving that on you guys, right? That's like a simple discussion. What is sickle cell disease and what is sickle cell trait? Yes, doctor. Anyone, please raise your hands. Anyone who want to answer? Dr. Shafiq, hello.
Yeah,
Dr.
hi, Doc.
Shafiq?
Yeah, I am with you.
Yes, Dr. Shafiq. Can you just please tell us what is sickle cell disease and what is sickle cell trait?
I know that sickle cell trait is the heterozygous. That,
Oh,
yeah,
if we have a normal B and a defective B, right? Beta chain, that is S, right? So we are going to have sickle cell trait. In this case, you are going to have 50% normal of your red blood cell, and the 50% are going to be like a sickle, right? Sickling on a stressful situation. While in sickle cell disease, we are going to have both of them defective, that is hemoglobin S, right? So it's going to be a severe form of sickle cell disease, right? So this was all about an overview of sickle cell disease and sickle cell trait. Yeah? So you already had an MCQ, if you guys remember. In sickle cell disease, you are going to have two kinds of hemoglobin. So Dr. Ami is going to answer that. Fetal and
HBS.
Hemoglobin S and
fetal
HbF.
hemoglobin. Perfect. And in the trait, we are going to have 50-50, right?
Yes, so there will be like a small amount of hemoglobin A that will be produced, and a small amount of hemoglobin S, and also if it is like child, there will be presence of hemoglobin F.
Perfect. That's perfect. So I'm just planning to have a 5 minutes of break. So we are just remained with like two topics for today, and with that, the red blood cells come to an end. So are you guys just enjoying the lectures, daily lectures, which I'm just taking out? Say.
Yes, doctor.
Yes,
It's
sir.
yes, Doc,
quite
yeah.
informative.
Okay.
Nice.
Thank you so much. So let's have 5 minutes of break. So those who haven't joined the Discord server, kindly join that. We are going to discuss the remaining UR MCQs. I'll be also there. So those who haven't, let me just announce we have just made a discount for the Discord server for you guys. So just please go and join that, right? So let's have 5 minutes
Doctor,
of break. Yes,
yeah,
please.
yes. I was like kind of trying to join the Discord server through that link, but it was like not
Okay,
working.
you have an updated link being shared by our
Okay,
by
I'll check
Dr.
that.
Hamza. So please just try that.
Sure, sure.